Awesome. We're really excited to have you here. I'm Alex Gassar. I'm the Pediatric Surgery Fellow at Brown. And the panel that we put together today is related to medical illustration and how it affects the care we provide to our patients every day. The learning objectives for our session, we're going to be talking about our experience with postoperative drawings in the neonatal intensive care unit and how visual communication enhances this patient care experience. And we'll talk a lot about the other words in that sentence later. We will be discussing the role of medical illustration and visual communication in the healthcare disparity arena. And we are going to help identify some tools for creating illustrations or diagrams in the clinical setting. My panelists are right here next to me. I also have the honor of working with them all the time. The first one's Dr. Lux. He is the pediatric surgeon-in-chief and division chief for pediatric surgery at my program. He also teaches a medical illustration course at the undergrad level at Brown University in the Rhode Island School of Design and the medical illustration elective for medical students. And he wrote that book that you see in the corner, MedSpeak Illuminated, and it's about medical illustration. The bottom person is Rebecca Herbert. She is a PGY3 in our program who is going out to research in a couple months and wants to be a pediatric surgeon now after working with us, obviously. And then she went to the Rhode Island School of Design, actually, before becoming a doctor. So she's also an artist by training and by trade. And then there's me. I just showed up to fellowship and happened to work with these incredible people. We work at both Hasbro Children's Hospital and Women and Infants Hospital, both in Providence, Rhode Island. And I'll just kind of get rolling. So how did we get here? This is probably the first drawing I made. Very early in my fellowship, we had a neck baby that just happened to come in a day when we were really busy. And we just did the case and had to move on for many other cases to follow. And first of all, I was like, what did we just do? Second of all, how am I going to remember this for the op note when I have to write like 10 op notes at the end of the day? So there was the first point. It was going to be my memory aid for the op note. I just wrote it in the back of my list and kind of moved on with my day. And then when my attending saw me drawing it on the corner, comes the next point. We actually got a chance to debrief about findings. The attending that I was working with, if you knew him, you'd know he's a very disagreeable person. So we never agree on what we find, but here we are. It was not him. It was not him. So we actually were like, okay, this is what we have. This is the lengths. Because ultimately what we get from our scrub deck of whoever's helping us is just some numbers that she scribbled down in like a little blue towel. So this is what we translated it to. And we kind of agree what condition the tissue was and what position. So it was actually a very good educational experience for me as well. And then the next thing that ended up happening is this was close to the weekend and someone else was taking over the care of this patient. So things like this became very useful for a surgeon transition of care. So what ends up happening later in the story is I just make more copies of this and put it under the door in the office of who I knew was going to be on call that night or the next day, etc. And what came after for this same patient is many other trips to the operating room. And as you see this progress, you also see kind of like the story of a patient is being told in pictures, the visual narrative. And you can also see the story of the fellow kind of getting a little more detailed in the things she puts on the op note. Like, you know, we left the drain. There's some distances. There's some scar from the old surgery. We did this thing. It didn't work. There's some notes from the old things. And then getting pretty fancy, you know, we start labeling the colors of the drains and where they're going for the nurses to know what's going on. We have an external drawing of the baby and where all the things are coming out, which ends up being very helpful in the department. So what ends up happening here is people see me drawing and then they're like, hey, are we getting that drawing? And I was like, no, this is my drawing. They're like, no, we all want this drawing. And I started getting paged by the NICU being like, we need the drawing. And if there was no drawing with the patient, they would not take my checkout unless there was a drawing. So it ended up becoming like every time I did a drawing, and now I was making 8 copies, and then there was a fight of like who got the original and who got the copies. It became a part of our electronic medical record. They were uploaded to Haiku, so everyone knew what we were talking about. And this was very helpful. In cases like this, where there was a chronicity of this, the NICU actually very proudly displayed the series of drawings in order in the patient's room on the wall, so that everyone who walked into the room knew this kid's story and also what stage of their care they were in. I was able to walk around the NICU and see rounds discussing the drawings, like where we're doing this for nutrition, or there may need more TPN because of this or that. And all of these things kind of just happened organically. Something that I was just doing selfishly became kind of like a cornerstone of the care that we were giving in the complex NICU population. There's other kids that, we got like take backs, and then we would be working on the previous drawing, kind of where we left off and what changes made. You'll start seeing here like mesenteric defects and other type of like things that made sense, so that the next time we were in the belly, we knew what was happening and why. And again, we'll have an outside picture, etc., and notice all the details. So in an emergency, you didn't have to read the full op note. You could just look at this and note what was going on. It also became an instrument to share kind of creative things we were doing. Here you see, for example, the incision, what side of the stoma was productive and which side of the stoma was a not productive one. That was important to the nurses. Here we had a kid that ended up with some innovative use of Foley that we called the Holy Foley. And it was a modified drain that we used to drain the biliopancreatic secretions away from a wound that we were trying to heal. We had a wound vac, and you can see the wound layers and the setup, and all of this was here because sometimes the wound vac stopped working in the middle of the night and we needed to know what was under there. There's also a notation of how the abdominal exam felt, so that the NICU fellows knew that that side was going to feel hard because it was all sponge. And then obviously the last steps in the care of these patients, and you can see that progress all over and over and over again. There's some drawings that we probably didn't need to make because they didn't need to see anything on the outside. A CDH is a CDH for them, but they demanded it, so we just started making them for whatever they asked. This has now translated to other opportunities. So we had a patient that unfortunately passed away, and the parents really wanted to know what their kid's anatomy was, but they were too overwhelmed to look at pictures, to look at the photos from the autopsy. So we ended up doing that drawing, and it was kind of very insightful for them to see what the baby's anatomy was and kind of understand the circumstances of the death. And then it was also very useful as we reviewed this in our morbidity and mortality conference with the NICU to understand kind of like the timeline of our interventions and how or why those interventions worked or didn't work as we were doing this. I've also used some of these drawings in my attempts at trying to train the residents to do cases with me. So we were doing a serial esophageal traction, and then we were going to take the patient for the final anastomosis. And I didn't want my PGY3 to be learning the steps as we were working in this child. So I made this little box for her with some gloves and a tissue box. And all of these, the drawings have become a form of communication, both for clinical care and education in our department. And then what happened is this resident that's sitting right here showed up to our rotation and was like, hey, this is art. I'm an artist. This is art. This is cool. And it's cool to see how these drawings actually affect patient care. And she actually reminded me of what would be the first drawing I made that was not a NICU baby, and that was a whole year when she was a PGY2, and it was a complicated patient on the floor who would not understand what was happening with his stomas. And I just came in and got a whiteboard and drew what was inside of him, and then that changed his whole therapeutic outlook on his own condition. And apparently she remembered that as part of her surgery training. But we decided to do a little survey in our NICU population regarding their perceptions of these drawings in the NICU patient care. And because this is not a scientific session, I'm not going to tell you all of the information, because you'll have to wait for whenever Rebecca presents it at a conference near you. But the important thing is, first of all, we pleased a lot of these people, which are really hard to please if you've ever worked in one of these places. Second of all, in general, it seemed to have a positive impact in many components of care. It helped guide multiple aspects of patient care to have these drawings at bedside. It addressed most of Picker's principles of patient-centered care, which is just a way of standardizing the components that we were talking about. And then people actually wanted them. No one answered that we shouldn't do these drawings. So 75% of people wanted them for every patient. 25% of people said that it was okay if only complex patients got them. We did an AI-powered thematic analysis of a lot of free text feedback that we got from the NICU group. And these kind of themes, these themes came up as the most important themes. Understanding communication, it's an educational tool. It allows to help and support families. It creates a consistency in care. There's specific value for complex cases and a general appreciation for current and future use. And you'll see, so AIML agree that this was good, agree with the nurses and everyone else. We had a lot of free text feedback. I'm obviously not going to put you through all of this, but these are the things that came up over and over again. The explaining, the understanding, the help with cross-covering, with handoff, individualized care and education, ensuring correct information is passed on, training, teaching, sign out among caregivers. There's thought about benefiting every patient. They really like them. They look forward to getting them. They think it should be a standard with every surgical baby. Thinking about of like in the setting of a synoptic op note and how that is important. This is also a visual accompaniment for that. It's not always easy to visualize what happened in the OR by a verbal explanation, something that was repeated, I think, by a lot of the neonatologists in particular. Education, reducing miscommunication, stimulating thoughtful conversation and care plan development. This was something that was really nice to see on rounds. And then this important one, it helps answer questions when no one else is around. Or for our team, it led to fewer and fewer pages in the middle of the night whenever shift change happened. But here's the cherry on top of the project is these kind of sentences. Emotionally at a level, it was supporting the families, this showing the progress of the patient's treatment. These families were keeping these drawings in their kids' memory books, in their albums. They were saving them like they were their treasures of being in the hospital. Many parents are non-medical, so that education and socioeconomic division between the provider team and the family was just, the gap was narrowed by all of this. They transcend language barriers, which was so just beautiful to hear that something so simple could be creating such a big difference. When medical terminology is intimidating, again, that more specific report with the family that was strengthened by this, and just providing consistent messaging. I think the NICU is a very scary environment, and when we're all on the same page, if this helps put several teams on the same page, then it's something that I think we can all get on board for. And this is where it just merges into Rebecca's talk. So she'll be talking about representation, diversity, and the history of medical illustration.
Hello, I'm Rebecca Herbert. It's an honor to be here. I'm a huge fan of Alex's drawings, and I'm just so excited that we're here kind of talking about all of this. I'm going to be going back in time a little bit because I think in order to talk about how to move forward with all of this, we kind of have to look at the past as well and what has gone right and gone wrong. So I'm here to talk about representation diversity and the shady and sublime history of medical illustration. Do not have any disclosures. So in terms of When we first start thinking about anatomy illustration, this is kind of our first example of medical illustration. There, around the time of the Renaissance, the 1500s, there was a huge push for exploring science through art. And this meant looking at anatomy and documenting this well with medical illustration. At the same time, however, it was very, very, very taboo to dissect bodies. And there was kind of an understanding that it wasn't legal yet, but executed criminals were unfortunately kind of fair game at this time. One of the earliest known documented events of this was Jacob Kerr's body. He was a criminal convicted of murder, and he was beheaded. And Vesalius, who was a famed anatomist at the time, collected his remains and documented this in his Atlas of Anatomy. And this kind of helped to shape the foundation of Western anatomy study. His skeleton is also, we don't know if it's officially the first, but it's the oldest known articulated skeleton that's preserved today. This also kind of led to, this became a little bit meta. There was art about art going on at the time. In the 1600s, Rembrandt would memorialize these dissections as civic theater. He kind of reinforced who was worthy of spectacle, aka the doctors, and who was a little bit more objectified would be these often anonymous bodies that were being dissected. At the same time, in England, the dissection of criminals was officially legalized, and anatomists could have 1 to 2 of these opportunities annually. And there were also exceptions made for stillborn babies and fetuses at the time as well. These are some examples of those works. And drawings were, as you can see here on the right, becoming a little bit more anatomically correct and advanced, and on the left, still a little bit of a characterization there. And then moving forward a bit to the mid-18th century, this was becoming more and more common. Drawings came a long way with increased anatomic accuracy, and it was no longer a legal issue, but more of a supply and demand issue. And this created a brand new market for grave robbers working together with anatomists. Very unique thing that developed at that time. So we've got here on the left a depiction of some grave robbers. In the center here, this is a much more detailed and anatomically correct drawing of a fetus in utero. And then over here on the right, this is John Hunter, who was another famous anatomist. He was alive during the late 1700s. So as grave robbing became more common, so did the efforts to prevent it. This was still, dissections were very, very taboo. Families did not want this for their loved ones. And if people were able to, they kind of would implement these pretty extreme contraptions. There were grave guns that I think were meant to be sort of like automatic weapons attached to the graves, as well as mort safes. And then there would also be watch houses like this one, where people would be observing the graveyards 24 hours a day to try and prevent grave robbing. Let's see. I think this slide, unfortunately, is blank, but it is, do I just click? I think that's my next one, though. Oh, no, here we go. Sorry. Apologies. So this unfortunately progressed even further, and there's even some instances of grave robbing getting to the point of murder. William Burke and William Hare were well known for committing 16 murders in the mid-1800s in Edinburgh, Scotland. They sold the bodies to Robert Knox for his anatomy courses. Edinburgh was a large hub of anatomy study and documentation at the time. Ironically, or perhaps not so ironically, William Burke was eventually hanged and his body was dissected in an anatomy course. Burking to this day is also used to mean to stifle or to kill, and this is the individual it refers to. There was a lot of public outcry at the time. I think probably the murders were not going over very well, understandably, and this led to the Anatomy Act of 1832, which authorized a person having lawful possession of a body to undergo anatomical dissection, provided that no relative objected. This, unfortunately, still often included prisoners, impoverished people from workhouses, unclaimed bodies, and children. This further entrenched a systemic exploitation. Around the same time, the question of whether somebody could donate their body to science kind of came up for the first time. I think one of the first known instances of this would be that of Charles Byrne and his interaction or intersection with John Hunter. This is Charles Byrne. He suffered from acromegaly and unfortunately by the age of 22 was already starting to suffer from the severe health effects of his condition, and it was clear that he would not be living for long. John Hunter offered him a substantial amount of money for his body after he died, and Charles Byrne declined this. He came up with a large, extensive plan to be buried at sea, and he had many friends involved to help him with this, including a lead coffin and helping to transport the body with a few different checkpoints before getting him to sea. Hunter did manage to intercept his remains along the way in this journey, and kept his skeleton in his private collection before it became part of the Hunterian Museum, where it was displayed for 2 centuries. In Byrne's case, the ethics of consent and death remain still unresolved to this day. About 10 years ago, there was actually a public survey that went out just asking everyone who is interested whether or not his remains should be buried at sea now, whether they should maintain the status quo and keep him in the museum, or if the remains should be retired from public view. About 55% of people voted for burial at sea. And I think about 30% voted for the status quo. So they didn't do anything at the time, interestingly, although I think the burial at sea was the majority. But 2 years ago, he was officially retired from public viewing, but has not gotten the burial he asked for. And then even more recently, in terms of anatomy illustration, we have from the mid-20th century the Perntkopf Atlas. Edward Perntkopf was the chief anatomist at the University of Vienna. He was also, unfortunately, openly sympathetic to National Socialism. This atlas was lauded at the time and still to this day as one of the best anatomy atlases in the world. And his collaborators were all more or less active in the Nazi regime. This is Eric Liepier, who would sign his drawings with a swastika, and Entresser, who would often use the SS logo in his drawings as well. These are some examples of the drawings, and which also may have been drawn from victims of the Nazi regime. These are some, not sure if you can see it there, but some of you can see in the tissue itself, the SS signature. And there's a swastika there with Liepier's name. So this begs the question of what do we do in situations like this? I feel like this is a very extreme example of something that we're faced with often in science, art, and music. Can you loathe the artist but love their work? Should you boycott the artist and their work? Or should work stand on its own merit? In terms of this atlas in particular, I think it's been difficult to kind of come to a consensus generally about it, and the onus of it is now kind of put on the individual. There's now an insert that is put into every single one of these atlases that says it cannot be excluded that certain preparations used for the illustrations in this atlas were obtained from political victims of the National Socialist regime, as well as from concentration camps. It's therefore within the individual user's ethical responsibility to decide whether and in which way he wishes to use this book. Which I think brings us to what would reparative justice in anatomy and medical illustration look like? I think in general, continuing efforts towards full burials of stolen remains. I hope that Charles Byrne one day gets his burial at sea, naming subjects in historical atlases, and more of this integrating ethical statements in anatomy courses and in texts like the one we just described. I trained in medical school at Tulane University, where they have an anatomy museum that they realized over the years many of the bodies that are displayed there were obtained in unethical ways. And they've made great efforts over the past 20 years to track down all of the families of those people. And they've either buried those bodies or, with permission that is well documented, they continue to display them there in the museum. So I think that's a great example of some things that we can do moving forward. Okay, so moving forward, I think we've well demonstrated that in the past, people that were dissected for the sake of science were often marginalized individuals. In contemporary medical illustration, these days, we are kind of often looking to educate people, the public, provide infographics about medications, provide general patient education, and then also educate people in medical school and beyond. Interestingly, now medical illustration kind of excludes a lot of groups of people. So these days, it's not immune to racism, sexism, ageism, weight discrimination, and Eurocentrism by ways of exclusion. I think this is a great example of that. We have some coronary artery disease infographics here. These all appear to be young 20-something-year-old men. It's very hard to find any of these advertisements or infographics that include women. I feel like all of these figures look like they have just run a marathon. So, we also have some menopause treatment advertisements depicting some women that I think must be in their 20s here. And then we have a newer trend. One of these was shown before in the CAD infographics, but there's this attempt at what I think is a bit of superficial diversity, but it's called the Blue Man illustration, and it's an attempt at being colorblind, but ultimately these figures all appear to be young Caucasian. So this lack of diversity in representation in medical textbooks affects diagnosis and care. I think that's something that we all know at this point in time, but we still need to come up with more efforts to fix. Dermatology textbooks are a great example of this. Historically, they've most often been about white skin, but melanoma and many other conditions look very, very different across different skin tones. And we could potentially miss deadly diagnoses if we're not all trained in how to recognize that. And I think with that in mind, medical illustration can be a great tool for activism. The American Medical Illustration Diversity Fellowship of 2023 chose 10 illustration laureates, each of whom created 10 illustrations. And this is not only using medical illustration for knowledge transmission, but also as a site of empowerment. And I think that brings us to the idea of participatory representation, that community co-design can shift agency and visual narratives of the body. And how can we create more initiatives like this that include subject communities in the creation of medical illustrations? And with that, I will turn it over to Dr. Lutz.
Thank you. Thank you. So I'm just here for comic relief and going to make it a little lighter. And I know I stand between us and lunch. So in the end of the conference, yeah. So I'm going to kind of finish the arc in a way and talk to you a little bit about practical ideas about how to draw. Alex was nice enough to already mention that I do have a conflict of interest, although I'm kind of proud of it as well. So this is about drawing for surgeons, but it's really going to be drawing by surgeons. So what can we do to make it better, and how did Alex progress in her fellowship, not only in surgery, but also in illustration. So it's not about creating a masterpiece. And sure, if you're an artist, and Rebecca is one, and there are others, sure, go ahead. But this is not what it's about. This is about visual communication. Try to make something clearer so that everybody understands and we're on the same page. It's not that difficult. We all know what we did. When you saw the examples that Alex presented, we know what operations we did. We know exactly what we did, so that's not the problem. We know what organs look like. I mean, a liver is sort of a triangular shape, more or less. The bladder is sort of a sphere. The kidneys are kidney-shaped. The colon is this kind of a weird question mark. So we know that. We also know how they relate to each other. And that, I think it's important, because we're all surgeons. We know our anatomy, so that's not that difficult. And also, it doesn't have to be that precise. This is great because this is nature. Very few things are very symmetrical in nature. So this is kind of the textbook illustration of bowel. But if you're not really good at drawing parallel lines, fine, call it peristalsis. It doesn't matter. Just to kind of borrow from a TikTok meme, we're surgeons. Of course, we know what organs look like. So that should not be a big problem. And if we forget, you can always hit the textbooks or the atlases or the x-rays. And sometimes regular flat plates or CAT scans can be kind of a nice memento or hook to remember what, the relationship is between the colon and the stomach and the other organs. So that can be helpful. So what I'm going to do in the next 12 minutes or so is not to teach you how to draw. In a way, we all have our go-to illustrations. This is one that I've used over and over again, and just with practice you get better. And so this is one, for example, that I would use to show branchial remnant, second branchial remnant, but you can use it for dermoid cyst, for preauricular, retroauricular cyst, for third branchial remnant. So with practice, you'll get, you don't need to be able to draw a full anatomical body. Just focus on the things that you do over and over and over again, as with bowel, as Alex showed before. So the idea is to just to get better and to organize and enhance your illustration. And that's what I'm going to spend a little bit of time on it. So if you are drawing, think about how to create a sketch, how to decide on the level of detail, how to use light and dark and shadows and outlines, and finally how to texture it, which sounds like very big art school words, but I'm going to try to kind of make it easy. So the first one is sort of important, and that's definitely true in art school, definitely true in medical illustration school, but what's your sketch? What's your point of view? And just a quick example, 2 ways of illustrating the head and neck. One, to illustrate how to do a needle cricothyroidotomy, and the other one, how to tape an ET tube. And you see here like very rudimentary forms to show your point of view, and you can make it a little more sophisticated just to show what I'm trying to illustrate. In a cricothyroidotomy, for example, most people are right-handed. I'm not, but most people are. And so you want to use your dominant hand to insert the needle right in the cricoid membrane, which means that you use your non-dominant hand or left hand to stabilize the trachea. So it makes perfect sense to show the head on the right and the non-dominant hand on the left. On the other hand, if you're going to illustrate how to tape an ET tube, most of the ET tubes are taped to the right, so it makes perfect sense to show the right side of the face. I mean, it sounds like stupid little examples, but think about how you want to illustrate and what you want to show, and that's the first step. Then you want to see what level of detail you want to have. Again, I keep on referring to Alex's drawings, and they got more and more sophisticated, but also you don't need to draw things that are not necessary. Keep it simple. For example, this is an illustration I did years ago about the difference, the reason why we don't need a balloon cuff on an ET tube in a newborn. I realize that now it's being used a lot just to have half sizes in a way. But essentially, the balloon in an adult or older child or adult is to stabilize the tube, not to create to avoid an air leak. It's just to stabilize it, because the narrowest portion of larynx and trachea in an adult are the vocal cords, which are kind of triangular in shape, as opposed to a newborn and infant, where the narrowest portion is a cricoid cartilage, which is round in cross section. And so what you see here is essentially only the things that you need. You see part of the ET tube, you see kind of a fine outline of a thyroid cartilage just to situate the area. Vocal cords don't look like that, but it's trying to bring a message. So keep it simple. And that was sort of reminded me of the revamping of the APSA logo, which is very detailed here. And this is exactly the same logo, but much simpler. So essentially keep it simple. Don't overthink it. And then what I'm going to talk for the rest of the last couple of minutes is essentially how to bring it to life. And the goal of any or most 2D illustrations is to make it look like it's a 3D, it's a volume. And artists use a lot of different tricks, but it always ends up being a sheet of paper or a screen, and it's flat and two-dimensional. Giving it volume really helps making it clearer. So you can make it artistic, but the whole point is how can you enhance the clarity. This is a brief sketch that one of my colleagues, pediatric urologist, years ago asked me to do for him, because he had a kid with a severe stenosis of the right ureter, and instead of, this leads to obstruction and dilation of the proximal ureter and the pelvis, the renal pelvis, and ultimately infections. And the best way probably is to do a nephrectomy. And he said, no, let me try something else. So cut it just above the obstruction, and then swing it over and anastomose it end to side to the other ureter. And this is fairly simple what he did, but with very little effort, you can make it look like that. And again, it may be clearer. So use it all the tricks that I'm going to show you now are more in the, just to make it clear, not necessarily to make it more beautiful. So it's all about didactics. For example, it's perfectly fine to show scissors like that. Everybody knows we're not going to use those scissors to cut it. Using arrows. Mary may remember that or recognize this illustration from an article you wrote. So use arrows, use anything, annotations, anything that can help. And so here, this is essentially Art 101. I did not go to art school, so Rebecca, please correct me. Oh, don't correct me. But essentially, by definition or by convention, light comes from top left. Why? We'll briefly talk about that in a second. I don't think anybody knows. From top makes sense because that's the sun, that's the light. But so if light comes from top left, that means that everything away from that light source will be darker. Very simple. So this works with very simple objects, simple structures, but it also works with very sophisticated and complex structures like those. I hope you recognize our founding fathers, but if you look at every single one of those portraits, you see how the side of their face that's close to the light source, that is top left, will be lighter than the other side. So it's an interesting exercise to look at photographs, paintings, and try to identify that. That's not the whole story. This is true for convex structures. So in convex structures, light comes from top left, so the opposite side will be in the dark. In concave structures, it's sort of the opposite, because the edge of the concavity closest to the light source will in fact cast a shadow on the object. And so that's going to be dark. And of course, the side away from it will also be in the dark. So this is a circle. That's all it is. If you add a little bit of light and shadows, you'll get a sphere. And if you do the opposite, you'll get a discoid structure. So you think about red blood cells, regular red blood cells and spherocytes. But in fact, it's not that specific. Most structures, certainly in the body, are combinations of convexities and concavities. So the duodenum, for example, on the outside, it's a convex structure. On the inside, it's a concave structure. So you can see that you make a difference between the lumen and the outside just by using different shades of gray. Same thing for the stomach, and same thing pretty much for any blood vessel or any other tubular structure. So I want to talk about dinosaurs. Why? Some of you may know the dinosaur footprints reservations. There are a couple of them in western Massachusetts. But essentially, if this is a example of not a dinosaur print or foot, but essentially in those mudlands, again, eons ago in western Massachusetts, the dinosaurs would leave a footprint in the mud, and then it would fill up in the rainy season, and then it would essentially become mud as well and then petrify, and then again, eons later, some people are able to carve out or to very, very carefully separate those prints, and they're all fossilized now. And so you end up having positives and negatives, right? And so you can visit those, and it's actually pretty fascinating because you see fossilized dinosaur prints like this one, and this is clearly a concave one, so this is a positive print, I'm sorry, a negative print, right? And this is very clearly a positive print, but in fact, they're both the same. And so just our brain, if we don't see the light source, automatically, intuitively, we think about light source coming from top left. So that's something that you can use, again, to bring illustrations to life. And I'm going to briefly talk about shadows, and that sounds a little frivolous because, why do you need to add shadows to it? This is a cartoon from the New Yorker from a couple of months ago, and the caption says, "It's annoying how you always wait until the last minute to do everything," which is not very funny until you see the shadow. And so the shadow tells you two things. They're really close to the ground. And also it's grass. You can see it's grass. So a shadow will tell you something about the structure itself and also the underlying structure. So it can help you enhance your illustration. So, for example, as I said, light comes from top left. So the dark area would be away from the light. And so you have the light here, and then you have the shadow that is cast on the opposite side. If the object touches the underlying surface, again, this is just a flat screen, as you well know. Even though you try to recreate a volume, make it look like a table, if the object touches the underlying surface, the shadow will touch that object as well. If the object does not touch the underlying surface, neither will the shadow most of the time. So this is just how you can very simply show that the object is not actually on the table. Again, back to the cartoon. Also, if the underlying surface is not flat, the shadow will be distorted as well. So you can see this here, the shadow now becomes distorted. Here's a sort of, not real life, but another example. You have B and C are clearly lying in front of A, and A happens to be flat, kind of a 2x4. And B and C right now are touching, but just by changing the position of the shadow, now you get the impression that C is coming towards you and is not touching. You can also, by changing the shape of the shadow, now it looks like it's a curved underlying surface. So you can play with that, and you got to experiment, but you can, again, enhance enhance your illustration by that. And here's there we go. An example, if you look, this is a posterior view, obviously, of the pancreas and the duodenum and the stomach. You can see that the common bile duct is a way that is, in this case, posterior and not touching the duodenum, but it comes close to it and, of course, touches the duodenum at the level of the ampulla. So just that adding that shadow gives 3 dimension and gives a relationship between the structures. Next thing I want to talk briefly about is line thickness, because if the goal is to create volumes, even though it's just on a 2D basis, you can use thick outlines to delineate the volumes themselves, as you can see here, and then you can use finer lines for the inner details, like this. You can also use finer lines for transparency. This implies it's a semi-transparent tube, the ET tube, and you see that the vocal cords in the left retinoid are finer lines as they go behind the tube, giving the impression of transparency. So you can use that for that as well. Finally, we're going to talk briefly about texturing, because that's another way to give it volume. And this is a random guy from the internet. But if you're an artist, great, but this is not about the art. So it's not about charcoal or any other mode, is trying to simplify it, make it easy and yet show the volume. So the first thing you want to do is consider any structure, any surface that is light, keep it white. So here we're cranking up the contrast. Note that we only have black and white, and it's still the same guy and it's still the same expression. So that's the idea. The most time-honored way to shade or to texture something is with hatching or cross-hatching, which takes a while, but also it's not that easy. You notice that even though it's done fairly well, not by me, you notice that it's still sort of irregular. You see on the side there is kind of this open wide area. If your problem, what you can do is what's called basket hatching, where you have random, very short segments of 4 or 5 lines crisscross, and that gives kind of a uniform impression of gray if you're interested in that. Or you can use stippling, which is a kind of elegant way of doing it, but it's pretty hard on your wrist. But it can be useful if you're doing illustrations for publication, black and white. That actually is a pretty useful one. It also may be used to show transparency, for example. See here the veins of a hand. This is definitely my favorite, and that's eyelashes. And eyelashes are just a couple of lines like that. You see why they're called eyelashes. And just by showing that, you show the viewer kind of the impression of convexity or concavity. You look at the thigh here. This is a pretty wide thigh, but those little lines just tell you that it's kind of convex or concave, as the case may be. So eyelashes, easy to show. Here you can show you, I don't want to criticize Alex's drawings, but you can see that with adding a few little lines, the bowel would have come to life. And it's not that complicated. It's still very good. And then you can combine the texture techniques. Here you have the eyelashes, and then you use stippling to show the texture of the tape, or in this case, showing kind of a gray watercolor cross-section of the heart to show the organic part of it, and then a very sleek synthetic digital line for the synthetic material of the cannula. And here are all the techniques combined. So in conclusion, medical illustration, it's not about art, or not just about art. It really is about visual communication. We all draw. We are all visual communications. We're surgeons. We like to see stuff. And so it's a question of can we get better? We can all learn the language and the skills. We need to practice the things that we need to use day in, day out. And ultimately, there's not a whole lot of difference between a good drawing of a dog and a bad drawing of a dog. Either way, it's still a dog. So thank you.
Thank you for joining us. I know you just went from NICU babies to Nazis and criminals to me being called out for not meeting my drawing EPAs. But do any of you have any questions for anyone up here? Yes, Dr. Brandt.
So I actually just have to tell a story. So I'm sure not very many people in the room know that Francois put himself through both college and medical school.
Medical school.
Medical school as a syndicated cartoonist in Europe. Oh, sorry. Thank you, sir. So Mary Brandt from Houston, and I think most people don't know that Francois put himself through medical school as a syndicated cartoonist in how many papers?
A couple of newspapers. It's Belgium. It's a small country.
It was a few more than that. Anyway, so when Francois arrived as my junior fellow at Saint-Justine, and I remember this so vividly, and I don't remember what the case was, but I knew it involved the chest, and it may have been a PDA, I don't know. And I walk in, he's dictated his operating note, and I look down and I was like, we have taken Metter as part of our program. There was this exquisite drawing in color of all of the anatomy of the chest and what they had done. And I was like, mind blown, right? And
Your memory is a little hazy there.
Do you remember what it was, though? I don't remember. But he looked at me and said, no, there's some principles here. And in literally 30 seconds, he showed me how to draw bowel. And I went on and did this in every case I ever did, particularly when it was complicated reconstruction in the GI tract, because I found it's so confusing to people. You know, you take the baby back and there's tubes. And so now you can show them where the tubes are going. And I just want to applaud you for bringing this. I want to applaud you for your incredible skill and your ability to teach it.
So I want to just stop you here, but thank you very much. But I have nothing to do with this. This is all Alex and Rebecca, and they brought me along again for comic relief. But it really is their initiative. And so I think it just proves that a lot of us draw, and yeah, why not get a little better? But yeah,
I applaud all of you for bringing this to us, and I think it's so important.
Also, I want to say one more thing.
It's fun.
I was giving a talk at Saint-Justine a couple of years ago, and somebody introduced me as, we remember how great an artist you were. And I wish that they had remembered you as how great a surgeon I was, but I'll take what I can. I'll take what I can.
Again, thank you all for that. That was really excellent. I've been a big fan of sketches and drawings throughout my career. To be able to convey somewhat complex surgical problems and techniques and procedures that we all do to families that may not have the medical literacy. So I'm a big fan, but your presentations have caused me to at least consider a couple of questions. One, do these drawings become part of the medical record? And if so, how about HIPAA compliance with that in terms of putting them on walls and having them copied and put out there? And secondly, should there be disclaimers on these, that is, to protect against what is on our drawing and what we maybe dictate? Could there be some discordance that could lead to some liability? I don't know the answer to those questions, but.
Alex, you want to take one?
Yeah, so on the just Epic, we use Epic. On the Epic side, the patients that go into the drawings that go into the patient chart have just their sticker. The OR is able to print a sticker just like a specimen, and they get scanned into it like that. The ones that I save for myself don't have any identifying information, and they don't really have PHI per se. If you go through the list of items that consist PHI, we have seen them, the ones on the walls in our NICU, it's a closed unit, everything that's in the room goes with the patient. So nothing per se. We do have a physical copy that goes into the chart that also has the patient sticker. Our NICU is actually at a different facility, so it has a different sticker than the one we have in the operating room for Haiku. And then the ones that the nurses use at bedside for checkout have patient stickers. The ones that the teams sometimes use to discuss it in conferences don't. And I have seen with patients that we have actually transferred to outside hospitals, they also refer to it in the chart because it is accessed in the medical record through MyChart or through Care Everywhere on Epic. So that has been useful. We haven't faced any issues. We've treated it with the same caution as any other picture or image that they may get from the chart. Our consents, when we consent anywhere for surgery, include some sort of photography and stuff like that. They don't specifically include drawings. We do ask the parents if they want them or not. We do kind of try our best to cover it. There's nothing specifically in writing about the legality of it. And we do try to include them in the UpNote, in the physical same document as an attached picture in line, usually in the findings section. So that also carries forward to try to make it uniform. What the measurements and the descriptions are.
And I suspect that now with the law that the patients have access to their own medical records, it's really not that different from having access to the UpNote. Of course, they need to be they need to agree, but that's the problem that we have. That's a bigger problem where some things don't always agree. But
yeah, thank you so much for this session. This is Pat Healy from Seattle Children's. I actually, the first time I saw sort of just sketches really used every day was my vascular rotation as a resident, and one of the attendings actually drew a sketch of every angiogram and then every anastomosis that he did, and I started doing that with whether, as you mentioned, different bowel anastomoses, different findings in the or organ like liver section. You can to kind of show things. I'm a transplant surgeon, so we frequently have to do vascular reconstructions. The grafts may have more than one artery. There's an anatomic anomalies, and I actually started sketching every single vascular anastomosis. And one of the things that, and it was part of my note, and actually the ultrasound people would look for that note, and because then they're going to be, we follow the grafts by ultrasound, and they want to know, okay, what's connected to what, or how many arteries are there, or we don't want to miss anything. Which vessel is this actually? Is it the internal, the external? And literally the notes would be, I'd get these texts from from the radiology tech saying, wait, where's your drawing? I need to scan this patient. And the diagrams would make it into the ultrasound record. So not that that was my goal, but it was incorporated right away, and I just found it very helpful. I never knew what all the hash marks were called, but I use a lot of eyelashes, so. And vessels, and I agree, the more you do it, you just, what do you want the picture to look like, and what do you want to show them? So you draw the things in the front, then you draw the things in the back. But I appreciate it, and thanks so much it tells the whole story, as you mentioned, across seeing them in series. Thank you.
Thank you. This is turning into an AA meeting. Hi,
I know.
I'm Pat Healy, and I draw.
But yeah, we've had a similar experience with our radiologists looking for the drawings and referring to them for their reads. Yeah.
Hi, Grant from Oklahoma. I actually trained with Alex partially before she went off to fellowship, and this is something that she started actually back in residency. We had a couple of very complicated patients with abdominal wall issues, and that she was the one who kind of pioneered them getting pictures into their chart and help with all of that. And it's something I've now picked up as well, to where I will start using it to actually help consent patients explaining an appendectomy to people who might not have the same language or things along those lines. It is a huge help to at least have a picture, because everybody, even lay patients, know like what the liver kind of looks like, what bowel looks like, and then you just draw this little worm that sticks off the end and they're like, oh, okay, it makes much more sense. So just wanted more comments on it.
Great. Just as a resource, we at Texas Children's, we did a study on professionally medical illustrator drawn perforated, non-perforated appendicitis, and made it part of the consent. But those images are available for anyone to use if you look them up. And we showed clearly that they understood better initially, and that they continue to understand that.
I'll even draw torque placement roughly so that they know like where the scars and bandages are going to be. That's pictures worth 1,000 words.
They are.
Yeah.
That's
Awesome.
as good as any ending of that.
Thank you.